Hello everybody, we are back and we're going to be doing more of the knee here. So in person, we began the knee joint and we talked about, we talked about the type of joint that the tibiofemoral joint is, a modified hinge. We talked about its articulating surfaces, the femoral condyles and tibial plateaus. We talked about the screw home mechanism. That's where we ended. And then the actual last thing we talked about was that the popliteal muscle, some say popliteal, I say popliteal. The popliteal muscle is the muscle that internally rotates at the tibia to quote unquote unlock the screw home mechanism from full extension. All right, so we're going to continue on. If you're following me in the notes, I'm looking at right underneath gliding movements. We're now at number 7, supporting structures. All right. So remember, we're talking about the tibiofemoral joint or the knee joint. So let's just finish talking about some of the supporting structures. And we're actually going to start with some of the bony landmarks. So we talked about the femoral condyles. Let me go back. Let's see this picture. The femoral condyles would be the rounded ends. I'm putting the femoral condyles in green. A condyle means a rounded end at an articulation or at a joint. And these are indeed rounded bumps at a joint. So we have medial and lateral femoral condyles. They're important because it is these femoral condyles that articulate with the tibial plateau of the tibia. Yeah. There's actually a separate portion that's higher called the epicondyle or smaller rounded bump. These would be the femoral epicondyles, but you don't need to know those. We're just going to stick with the important ones that form the knee joint, the medial and lateral condyles. I do want to mention, though, the intercondylar notch. Excuse me. If we look at the word, come on, folks, intercondylar. So between the condyles is a space. So remember, here are this would be the lateral femoral condyle, and this is the medial femoral condyle, the rounded ends of the bone. And in red, there's a space. The space in between is the intercondylar notch. This is important because it is the space that the anterior cruciate ligament runs through. And we're going to be talking about the ACL quite a bit in a moment, but you can see the ACL is right here. It literally runs through the intercondylar notch. So please know that. Some side things that you don't need to know, but we're going to talk about anyway. The intercondylar notch is a little bit narrower in females, just because females tend to have a narrower and smaller bone structure. But this might be one precipitating factor why ACL tears are so much more common in women compared to men. All right, let's talk about the popliteal fossa. So on the posterior aspect of the knee, we talked about the popliteus muscle, right? This is the popliteus muscle. Well, on the back, in between the femoral condyles, in the front, the space in between the femoral condyles is the intercondylar notch, right? So between the femoral condyles on the front, anteriorly, intercondylar notch, that space. But when we look posteriorly, the space between the femoral condyles posteriorly, popliteal fossa. Why is it there? Well, it's important because it's a big old space that nerves, arteries, and veins travel through. So a big bundle of vessels and nerves passes through there. Okay. I'm just checking my notes to make sure I'm asking you what I want you to know. So just be able to identify these anatomical structures. The opening on the posterior side between the femoral condyles is the popliteal fossa. I'm going to review for you the tibial plateaus. We already talked about that, right? So the actual knee joint or the tibiofemoral joint is formed by the medial and lateral femoral condyles, I put in green, and then the tibial plateaus in red. There is a little bit of a depression up there. Make sure you review the big bump on the anterior part of the tibia, tibial tuberosity. You'll see on your sheet there is a little raised bump between the condyles called the intercondylar eminence, but you don't need to know that. And then just be aware that the head of the fibula is here. And I'm going to point that out, the head of the fibula, as a reminder, just anatomically where it is, because we can see that the fibula does not make part of the knee joint. The knee joint is the tibia and the femur, and that's it, not the fibula. All right. A lot of good pictures here that we're going to come back to again, but pictures that show you the bones, the ligaments, the muscles, a lot of good stuff. I mean, let's be honest, I always think they're good stuff, but you might actually agree this time. All right. Let's get down to business with the ligaments. Alrighty. And maybe you've had some of this before. I'm going to just grab a drink of water here. Hold on. Pardon me, sorry. So we basically have two different sets of ligaments. We're going to start with the anterior and posterior cruciate. So our first set of ligaments are the cruciate ligaments, anterior cruciate and posterior cruciate. These form an X in the center of the joint. They run through, particularly the ACL runs through the intercondylar knot. By the way, cruciate means to cross, so don't these cross each other. Let's first talk about the anterior cruciate ligament. Of the two ligaments in the middle of the knee that form an X, the anterior, well, it's more anterior. It's more visible from the anterior. It technically runs from the anterior medial tibia back to the posterior, oh, I didn't mean for it to make that. Let's try it again here. It starts at the anterior medial tibia and it runs back to the posterior lateral femur. So it's at an angle there. Let's talk about function. The anterior cruciate and posterior cruciate, they are there to prevent. Hold on, let me check my notes here to make sure. I'm just checking to see how detailed I want to get here. Yeah. They prevent excessive anterior and posterior femoral translation. Let me write that down for you. They prevent excessive anterior and posterior femoral translation. I'm going to bring a model in when we meet for lecture next time, and maybe I'll bring it to lab too, so we can see this. But basically, this is a way to prevent the tibia and the femur moving either moving too far anterior or posterior. Without these ligaments, you might be able to imagine that the femur could just slide all the way anteriorly and never stop. Right? This isn't like a ball and socket where the head of a femur, for example, fits like a glove into the socket. So it's not like that. We really just have two bones resting on top of each other, and that's it. So to prevent the tibia or the femur, really, from moving too far forward or backward, we have these ligaments. We expect a little bit of give as we move around. the femur might slide a little bit anteriorly or posterior on the tibia, but we don't want excessive. This will make more sense when I bring in the model. All right, really important. We'll talk more about ACL tears later, but super important there. And then, of course, on the posterior side, let me see. Okay. On the posterior side, I don't have a great picture. On this picture here, this, wait a minute. Yeah, we're just going to look at it this way. Pardon me. Let's look at, so the PCL runs behind the ACL. So if the ACL is in red here, right? Anterior medial tibia to posterior lateral femur, the PCL runs exactly opposite it, from the posterior medial, no, anterior posterior tibia to the posterior lateral femur. You don't need to know which direction. Just need to know that the ACL and the PCL form an X in the center of the joint. Anterior one is more visual on the anterior side, and that they work together to prevent excessive anterior and posterior translation of the femur on the tibia. Technically, the PCL has a couple separate bands, but we tend to just talk about the posterior cruciate ligament as one. It is shorter in length than the ACL, but it's stronger. So there's many reasons why the PCL doesn't get injured as often. First of all, the PCL is stronger than the ACL, but also it's just a less common mechanism that would stretch the PCL too much. But it does happen. It does happen. All right, so those are the basics of our first set of ligaments. The ligaments, the anterior and posterior cruciate, that form an X in the center of the joint, and they prevent excessive anterior and posterior translation of the femur on the tibia. Well, then we also have a medial collateral and lateral collateral. We saw a similar thing with the elbow, right? Well, here we see it again, and you're probably more familiar with these. On the medial side, it's the tibial or medial collateral ligament. Collateral ligaments, instead of forming an X in the center of the joint like the cruciates, the collaterals run alongside, the inside or outside. So the MCL runs on the inside of the knee joint. I can tell it's the inside here because it's the same side as the tibia. And then the LCL runs along the outside, attaches to the head of the fibula. You could call it the fibular collateral or lateral collateral, right? LCL. Let's just look at some differences between the two. So if we just look at the two, the medial collateral ligament blends in with the capsule. So look at the tibial or medial collateral ligament of the knee. It's much closer to the knee joint, and it actually kind of rests right against the bones, and it blends in with the actual joint capsule. It's a little bit broader and thicker than the LCL. So the MCL is broader, thicker, closer. It blends in with the joint capsule. On the other hand, the LCL is thinner, but a little bit rounder. So the LCL is almost more rope-like. The MCL tends to be thicker but broad, like thick all the way through, not just a rope, but thick, yeah, more broad. But the LCL tends to be more rope-like, kind of thinner, but more rope-like. And the LCL is a little bit further away from the joint, right? You can see that here. All right. The function. So, and I really like this picture. And because you studied so hard for the last test, you already remember valgus Remember that I talked about a valgus force on the elbow? Well, we can also see it here with the knee, and I think I even used the knee as an example before because that's kind of easier. A valgus is a force that's a lateral force. I know this is lateral because the fibula is lateral. A valgus force is going to stress the MCL. So, for that reason, we say the function of the MCL, medial collateral ligament, prevent against excessive valgus and rotational forces. When there's a side to side, so you see the cruciates that form the X in the center of the joint, they're more responsible for preventing excessive anterior or posterior movement of the femur on the tibia. But on the collaterals here, they're there to protect side-to-side forces and motion. When there's a valgus force, we know the MCL is there to hold the knee intact. If that valgus force is excessive, it could tear the MCL. But in general, we can just say the function of the medial collateral ligament of the knee prevent against excessive valgus and rotational forces. On the other hand, we have the LCL, right? And the LCL prevents against excessive varus forces. This is a force in blue from the medial side, right? Isn't this the medial bone, the tibia? So a varus force will stretch the lateral collateral ligament. So whereas the MCL prevents against excessive valgus and rotational forces, the LCL prevents against excessive varus and rotational forces. Good, good, good. Which one is injured more commonly? I can't hear you. Definitely the MCL. The reason why the MCL is much more prone to injury by and large is because it's much more likely to have a valgus force. This is a much more likely, even in the course of everyday activities, but especially with sports. Much more common to have a medial collateral ligament because much more common to have a valgus force. All right, good stuff. So I've tried to give you as much as I can. Here's a great X-ray, an AP view, an anterior view, and then a lateral view. Look on the left here. What a great way to see the tibial plateau. Remember saying the tibial plateaus? It is a bit of a plateau. And then we can see the femoral condyles coming down. Really cool. We can see how the bones fit together. So on the right-hand side, they purposely flexed the knee a little bit. So we can see the femoral condyle actually articulating with or touching tibial plateau. Now on the left here, if we were going to draw in the ligaments, wouldn't the ACL would run just like this, right in the middle, and then the PCL would run behind it like that. And then we'd have the MCL right there, and then we'd have the LCL right there. Excellent. Oh, there's an MRI. Check it out. Really cool. I love this stuff. Okay. So the next thing on here, it says transverse ligament. And I was hoping it would show this in this picture. Let's see, is there one here? I thought I had a picture that showed it. Guess not. All right, well, I can just describe it. The transverse ligament connects the medial and lateral meniscus. We're going to address the medial and lateral meniscus shortly. These are the added rings of cartilage, right? So here's this added piece of fibrocartilage for shock absorption. Well, it turns out that the medial and lateral meniscus are connected by a transverse ligament. Thought I had a picture here. Pardon me for going back and forth so much. All right. Don't have a picture, but just know what it does. The transverse ligament connects the medial and lateral meniscus. Transverse ligament connects the medial and lateral meniscus. Pardon me, another drink. All right, number 6 there, oblique and arcuate popliteal ligaments. You don't need to know these. You don't need to know them. I'm just going to make a point here as an aside. We know that we talked about the anterior cruciate and posterior cruciate ligaments. Form an X, middle of the joint, great. Well, it turns out on the posterior side, there's something that we call the posterior ligament complex. You don't need to know this. You don't need to know it. But if you're interested in learning just a little extra or just in one ear and out the other for this, but not the rest, there's actually a combination of ligaments on the back. So here we can see this picture shows you some of those. So the oblique popliteal is this one. And then the arcuate popliteal is this one. But they tend to form the posterior ligament complex. You don't need to know that. Just saying that there's more ligaments on the back. Don't need to know it. Okay, let's talk about these menisci. Everyone's heard of the meniscus, right? I think so. Let me go back. Sorry if I'm giving you a headache moving back and forth so much. This is a nice picture to start with. So the menisci are just added pieces of cartilage for shock absorption. Of course, we always have some hyaline or articular cartilage. So this light purple color is showing us a little bit of hyaline cartilage that lines the ends of all the long bones. So we always have a little bit of cartilage, kind of like a glove. But with the knee, there's so much compressive forces. It's beneficial for us to have an added piece of cartilage. And that's what the menisci are. An added piece of fibrocartilage, which means pretty thick. And there's an added wedge of cartilage on the medial side. Look at that, great. And an added piece on the lateral side. So added piece of cartilage, thick cartilage for shock absorption. Added piece of cartilage for shock absorption. How would you know medial versus lateral? Because you would look down here. The tibia is always on the medial side. It's a medial bone. And the fibula is always the lateral lower leg bone. This happens to be a right knee, right leg. But I know this is the medial meniscus, same side as the tibia, which is the medial bone. Let's talk a little bit more about these menisci. I mean, they're great, folks. They're absolutely great because they give a lot of shock absorption. If you look at the shape of each, the medial meniscus tends to be a little bit more C-shaped. And I would like you to know this, right? The medial meniscus is kind of more, like it's like a backwards C. The lateral meniscus is more, sometimes people say O-shaped, because it goes almost all the way around. So they're shaped a little bit differently just because of the contours of the bone, contours of the tibia. These, of course, rest on the tibial plateaus. So actually, the tibiofemoral joint is the femoral condyles resting on the menisci, but the menisci are resting on the tibial plateaus. I know, fun stuff, huh? It may have been fun in January, it's not fun now. It'll be fun when the semester is over, my friends. So they're shaped a little bit differently. The medial is a little bit more like a backwards C, and the lateral is more like an O. We already gave the functions, shock absorption. They do help to distribute the load, the compressive load of the body weight. Here on the bottom right is the meniscectomy. They've taken the meniscus out, which, by the way, they usually don't do that much anymore. Back when I was like 20 years ago, they used to just, oh, you got a meniscus problem? We'll just take it out. But then they found that there was such a higher incidence of arthritis. So sometimes they'll go off and shave a little piece of it, but they, as far as I know, they try and shy away from taking the whole thing out when they can. in this little view here, if you look in the middle, do you see that little line? That's what's called a bucket handle tear. So you might get a meniscal tear on the outside, like you might get a little tear here or here, but sometimes you can get a tear right in the middle of it, right in the middle. So you might get a tear like this, bucket handle tear. That's going to be much harder to repair. If you have a tear just on the outside, they can go in and maybe shave that off, but you don't want to see a bucket handle tear. Okay, looking at the menisci, they have a poor overall blood supply. This is a bad drawing, but I think by now you've come to know that about me. Bad drawing. But, you know, bone tends to have a really good blood supply. Muscle has a pretty good blood supply. Cartilage does not. And we see that here. So one reason why meniscal injuries are such a pain is because the meniscus tends to have a poor blood supply. Here, I've taken the medial meniscus, right, that backward C shape, and I have enlarged it. And I just want to point out the outer regions, so what I have in green, the outer regions have the best blood supply. Still not great, but it's better. So if we have a tear in the outer third, much better prognosis, right? Maybe it'll heal a little bit on its own. Maybe we can go in there and just shave a bit off. But as we go further and further in, or medial, it goes from having an okay blood supply to a poor blood supply to very little to no blood supply. So just know this in general. The outer rim has the better blood supply. Still not great, but the outer rim has the better blood supply. It gets worse as you move medial. All right. Other side things that I want to point out. If I go back, I think, let's see, we can see it best in this picture probably. If you look at the menisci, the outer rim is thicker. Again, this is just extra, but it's like thicker on the outer rim and it gets a little thinner. So it's thicker on the outer. So it's got like a thicker edge and it gets a little bit thinner, more towards the middle. Another, just as an aside, if you look at the lateral meniscus, it does attach a little bit to the ACL, and that's what it's showing there. The LCL, excuse me, why do I keep saying that? The lateral meniscus attaches to the ACL. Extra. Okay, a couple other extra anatomy things. Joint capsule. So we know that every synovial joint has a connective tissue wrapping around it. I keep saying it looks kind of like saran wrap, right? No different here. The joint capsule tends to cover most of the tibiofemoral and the patellofemoral joint. It's kind of hard to really visualize. If I was going to draw the joint capsule, I'd kind of draw it like that. So it encapsulates both the tibiofemoral and the patellofemoral. I know this picture on the left is a little confusing that way, but I just want the joint capsule here covers not only the knee joint, the tibiofemoral, but it also covers the patellofemoral joint. This happens to be the largest joint capsule in the body, larger than the hip even. So I'd like you to know that, right? Yes, yes, yes. You can see some other things. It's a relatively thin and loose joint capsule. Okay. So my one point that I wanted to really bring home to you is that this is a big joint capsule, covers the tibiofemoral and the patellofemoral joints. That's point number one. Point number two is, when it comes to the knee, we often refer to structures as intracapsular, which means within the joint capsule, or extracapsular, outside of the joint capsule. Let's start with extracapsular. The structures that are considered extracapsular are the collateral ligaments. So it's kind of a weird picture here. You don't want to get a good look here to see the medial and lateral collateral ligaments. But the LCL and MCL, if you remember, I said the MCL kind of blends in with the joint capsule. So these are far out enough. And actually, that's mostly the case for most ligaments. The elbow, for example, all of its ligaments are extracapsular. The shoulder, its ligaments are extracapsular. The hip, its ligaments are extracapsular. So this is the norm, right? What is unique is that we have those intracapsular ligaments, and it should be no surprise, the cruciate ligaments. I mean, haven't we been saying that the anterior and posterior cruciate ligament form an X in the middle of the joint? So they're literally within the joint capsule. The menisci are also within the joint capsule. So first, be able to identify what structures are intracapsular and which are extracapsular. Of the ligaments, the collateral ligaments are extracapsular. The cruciate ligaments are intracapsular. Let's talk about some practical applications. Some practical applications can revolve around swelling. So let's take the ACL, for example. It is intracapsular. If you tear the ACL, it's going to swell. You've torn some tissue, there'll be some inflammation, yes. But because the ACL is intracapsular, the swelling tends to go everywhere inside the joint. Have you ever seen someone tear their ACL? Maybe you've experienced it, unfortunately. Actually, in many instances, people who tear their ACL actually have swelling and pain on the back of their knee, which might seem kind of weird, like why is there swelling and pain on the back of the knee? Well, if everything's intracapsular, the swelling is just going to go where gravity takes it. And gravity tends to make it fall lower in the capsule and more posterior. So just because, in other words, because it's intracapsular, the pain isn't necessarily localized to where the damage happened. On the other hand, the MCL, because it's extracapsular, that swelling tends to be more localized. So if someone tears their ACL, they're going to have swelling or pain on the medial side. It's more localized. They're going to have swelling where the injury is on the medial collateral ligament. Whereas these intracapsular structures, because they're all in the capsule together, sometimes the swelling and the pain can be more spread out. So you can also use that, if that terminology. Swelling and pain is more spread out. So a good practical example, right? Lastly, please make sure you review the different types of swelling. Edema is probably what you've heard of before, swelling in soft tissue. Well, now we're going to add a new one, effusion. Effusion is referring to swelling inside of a joint. So an ACL tear will result in effusion. When we have damage and inflammation from an intracapsular structure, we will have effusion or swelling inside of the joint capsule. Okay, almost last piece of anatomy for the knee joint is bursa. We've gone over this enough. You know what a bursa is, a fluid-filled sac. We have them here as well. I just want to point out some. We have the suprapatellar And these are named for where they are underneath the patella superiorly. Then we have a pre-patellar, and that's on top of the patella, superficial to it, and a deep infrapatellar, which is behind. You don't need to know the specific names, just that they exist. And I want to point out the presence of a fat pad. Yes, ladies and gentlemen, we all have fat in our knees. These fat pads serve a really good purpose. It's a special kind of shock absorption, a strong shock absorption. The other place that I can think of that's a good example of a fat pad is underneath your heel, underneath your calcaneus. But don't need to know that specifically. I'm just pointing out that it's there. The last thing I would like you to know is the IT band. We talked about it in lab with the hip last week, iliotibial band. Thick connective tissue band that runs from the ilium to the tibia, right? It starts at the ilium and it runs all the way down, actually below the knee to the tibia. You probably might be more familiar with this if it gets tight or inflamed. Runs along the outside. Thick connective tissue band. Alrighty. I want to keep on going for a little bit here. So now we're going to move into the patellofemoral joint. We were previously talking all about the tibiofemoral. Now let's talk about the patellofemoral. As the name suggests, pardon me again, as the name suggests, this is formed by the patella and the femur. Patella, femur. These bones are not always touching. When we are in full extension, they are not touching, right? These bones begin to touch at about 20 degrees of flexion. So when you're fully extended at your knee, not touching, and you can actually move your patella around because it's not touching the femur, and we're going to be able to do that in lab. But when we flex our knee to about 20 degrees and on from there, there is contact between the patella and the femur. Therefore, patellofemoral joint. I want to remind you that the patella is a sesamoid bone. The patella is a sesamoid bone. That means free floating. We only have 3 bones in our body that are considered sesamoid that don't touch other bones. The patella does touch the femur at certain ranges of motion, but also if I'm fully extended at my knee, the patella doesn't touch anything. Sesamoid bone. The other examples of our sesamoid bones would be the hyoid bone. That's the semicircle shaped bone in your neck. Does not touch another bone. And then we do have 2 small pebble shaped bones underneath our big toe called sesamoid bones. Maybe you've heard of, sometimes a runner might get sesamoiditis, inflammation of the sesamoid bones under the big toe. But here, the patella is sesamoid bone. Okay. The articulating surfaces, I'm just going to say that the underside, let me switch to blue. The underside of the patella is kind of contoured. Can you see that? So the articulating surfaces are the underside of the patella and this groove in the femur. Patellofemoral groove. So the articulating surfaces, when they do touch, would be the underside of the patella and the patellofemoral groove of the femur. So you can see that the patella is kind of contoured and it's convex, kind of comes out a little, juts out, and the convex surface of the patella fits into the concave surface of the patellofemoral groove. We can see that convex surface over here, right? So look, the patella, the underside kind of bows out, and it's going to fit into this groove that's kind of a concave. It's a depression. This is a plane or gliding joint. Type of joint, plane or gliding. What type of motions are allowed? Gliding upwards and downwards. So it's a gliding or plane joint. And as we flex our knee, the patella glides upwards and downwards within that patellofemoral groove. Okay, glides. We're going to assess this in lab. We're going to have you palpate the patella, identify its location, and then we're going to see how it glides in that patellofemoral groove. As you flex and extend your knee, the patella should glide relatively straight up and down. In some people, the patella might sit a little too far to the side, or it might not glide enough, or it might glide too much and be hypermobile. There is a slight tilt in the patella as well, but don't worry about it. Gliding joint glides up and down. Okay. So this shows you at different angles of flexion, 0 degrees up top, 20 degrees, and then 40 degrees in knee flexion, how that patella sits in the groove. Don't get too worried about this, but what we can notice again is the underside of the patella is concave, and then the patellofemoral groove is convex. So they're meant to glide together. So this underside should fit right where it's supposed to, but what if this patella is too far medial? In this picture, that's what it's trying to show you. So if that patella is not fitting in the groove properly, you could have some patellofemoral dysfunction. Patellofemoral pain syndrome. Okay, what I think we'll do here is we'll finish talking about the bony anatomy, and then we'll start the muscles. We're going to review those in lab, and then we'll go on from there. So almost done here. Thanks for staying with me. I want to talk a little bit about this patella, though. Why? I mean, if you've ever thought about it, isn't it kind of a weird arrangement? We got the big old femur, pretty big tibia, great joint for motion. Why would we have this weird shaped sesamoid bone on top there? So there actually are some important functions of the patella. One of them is that it increases the angle of pull. Increases angle of pull of the quadriceps. So we know the quadriceps are up here. Here are the quads. The quadriceps tendon crosses over the patella, and the quadriceps attach on the tibial tuberosity. So this is what I mean when I say increases the pull of the quadriceps. When the quadriceps contracts, isn't it going to pull up this way? Yes. And as it does that, imagine the patella acting like a pulley. If you had a rope going up around a pulley, you can generate more tension, more force with that system. So it increases the angle of pull of the patella. According to my reading, it says that it can improve this pull of the quadriceps by 50%. Increases angle of pull. 50% better. It actually better we have 4 quad muscles, right? We got the vastus lateralis, rectus femoris, and vastus intermedius. We have the vastus lateralis. They form one common tendon. And that one common tendon goes over top here and down, and that pulley system increases the angle of pull. It brings all those 4 quad tendons together into one. All right. The third function there is protection. Because the knee is so exposed, having that bone on the top does give a little bit of bony protection. And then letter B there, you don't need to know letter B. You need to know A and C. Increases angle of pull of quadriceps, protection. If you're wondering, letter B there, increases area of contact between the patellar tendon on femur. It basically is a way to, yeah, we're just going to skip that. I don't want to get into that. All right, but this is a real thing, right? This is a real arrangement. And like I said, it's no joke here. Increases the angle of pull. It can increase the function of the quadriceps by as much as 50%. So that's really cool. All right, the last thing we'll do before we leave here is the proximal tibiofibular joint. So we talked about the tibiofemoral joint, knee. We've mentioned the patellofemoral joint, which kind of works with the knee. But another one further down is the proximal tibiofibular, joint between the tibia and the fibula, head of the fibula on the side of the tibia. We're not going to talk much about it. There's not really much motion here. I'm just saying it exists and it's separate from the knee. All right. I will see you in lab and then we'll pick up where we left off for the lecture. Keep working hard, folks.